Okay, so I think we are ready. And this is 12:30, and we are going to the live streaming as well. Okay, good afternoon, everyone, and thank you so much for joining us today. Let me just let other people in before I want to start. Thank you so much for joining us today. So please feel free if you would like to keep your video on and if you're comfortable to do so. I'm Yasmin and I am the Education and Training Coordinator of MAHSC and Biomedical Research Centre, BRC. I am honoured to welcome all of you to our next lecture of the MAHSC Inaugural Lecture Series, which is celebrating the incredible honorary MAHSC clinical chairs. So today we will have Professor Smeeta Sinha, which will be introduced by Professor Ellie Cartwright. And then we will have Professor Nick Lees, which will be introduced by Professor Karen Piper-Hunley. So we are looking forward to celebrating both of you, Professor Lees and Professor Sinha. And so if you do have any questions or comments, please feel free to put in the chat box, which will be covered by the end of each talk. I will hand it over to Ellie, please, if you would like to introduce Smeeta.
Hi, thanks very much, Yasmin. So I'm Professor Ellie Cartwright. I'm head of the Division of Cardiovascular Sciences at the University of Manchester, and it's a real honour to have been asked to introduce Smeeta to give her MAHSC inaugural lecture. So as you're no doubt aware, MAHSC is this organisation that brings together healthcare professionals, academics and researchers with its aim to drive forward research and make new scientific discoveries that benefit patients. And so we're here to celebrate Smeeta's award of a MAHSC honorary clinical chair, which is an appointment that the University of Manchester recognises the achievements of distinguished individuals from the NHS. So, and it's a fantastic recognition, and it's one that's really hard won. To receive an award like this, you have to be making outstanding contributions in your clinical profession, along with conducting excellent quality research and teaching as well. And Smeeta excels in all of these areas. So as a consultant in nephrology, Smeeta's known nationally and internationally for her expertise in vascular calcification, and she's leading research in the rare and really devastating disorder of calciphylaxis. And she's also very much involved in revolutionising outpatient care for patients with chronic kidney disease. I can tell from her CV that Smeeta's been in Manchester throughout her research career, embedded within the fantastic renal teams that we have here, with whom she regularly publishes in leading journals. So on top of her clinical and research roles, Smeeta has long made considerable contributions to leadership. So nationally, she's the NHS England National Clinical Director for Renal Medicine and clinical lead for the Renal Services Transformation Programme. And then more locally, she has a role as the Deputy Director of Research and Innovation at Northern Care Alliance. This is really focusing on embedding innovation within the organisation and developing external partnerships that facilitate translational research. So Smeeta also makes really valuable contributions to medical education, so through her PhD and undergraduate project supervision and teaching of undergraduate students. So collectively, these contributions to clinical excellence, through her leadership, research, innovation and education, really makes Smeeta a very worthy appointee of a MAHSC honorary clinical chair. So, without further ado, it's my pleasure to hand over the virtual floor to Professor Smeeta Sinha to give her talk, Vascular Calcification in Chronic Kidney Disease. Thanks, Smeeta.
Gosh, thank you so much, Professor Cartwright. Right, I'll see if I can try and do justice to all of that. So bear with me, and thank you so much for giving me a MAHSC honorary chair. It is very much appreciated and a real opportunity to take forward as well. So one moment, please. Right, I'll just go to full screen. Hopefully you can see my slides. Yep, good, I can see some nods. So over the course of the next 20 minutes or so, I'm going to cover 3 areas: me, my research career, and how that has intersected with my leadership career, and the two are very much intertwined. So I'm 47 years old. I'm the daughter of a doctor and a Wonder Woman. That is very much who my mother is. My father sadly passed when I was 18 years old, and my mother has carried the family through, and a lot of the values and the inability to say no to things or say no to people comes from my mother. But it has given me so many opportunities for which I will forever be grateful. I graduated from the University of Manchester, so as Professor Cartwright says, I have been here an awfully long time. And I took time out of training, my medical training, to undertake a laboratory-based PhD on vascular calcification in the Canfield lab. I became a consultant nephrologist in 2010, and since then I've had what in the medical career we like to refer to as a portfolio career, where I've had a blend of research, leadership and management and teaching. And I formally became a deputy director in 2021 and the national clinical director for renal services in 2022. And the pinnacle of 15 years of work, we completed our phase 3 global randomized control trial last year. So I'm going to try and briefly touch on all of these as I go through. So my early years were very much spent doing exams, nights on call, but I did meet the husband. That was probably the only achievement in the first 4 years. And then I went on to train as a renal registrar. And that's when I met Professor Phil Calra, who, for those of you who haven't met him, when you do, you will see that he's absolutely passionate about research, but also about developing people into researchers. And he was the first person who I suggest I ought to do a PhD. And he has very much become my career mentor. And I know I'm not the only one. For those of you that have watched Darren Green's presentation, you'll see similar themes. Absolutely a force of nature, particularly within renal services and wider. So this was my PhD, and I did it in the Michael Smith building, just around the corner. So it was looking at the effects of nitrogen and non-nitrogen containing bisphosphonates on vascular smooth muscle cells. Don't worry, I'm not going to go into the details of my PhD, but I will try and cover some of the themes. And the reason why this was particularly important was vascular calcification is highly prevalent in people living with CKD. There are different types of vascular calcification. So the atherosclerotic type that we typically see in people with atherosclerotic disease leading to heart attacks. But we also see medial calcification, calcification in the heart valves, and then a rare form of calcification called calciphylaxis, which is a type of medial calcification, but very devastating. And this slide is really old, but it highlights the prevalence of vascular calcification in CKD. So it starts before people even need dialysis, but by the time they start dialysis, over half of them already have evidence of calcification. And after they've been on for over a year, you're looking at 83%. So this is something that we were seeing in everyday practice. It's not just something you see, it's actually something that impacts outcomes. So if you look at different measures of vascular calcification and the impact on mortality, whether you have intimal or medial calcification, it increases your risk of death. And that's all-cause death or cardiovascular death. So we're starting to see the impacts of the cardiovascular system and the kidney disease coming together. And the two also are intricately linked. As you've heard as part of the Donald O'Donoghue Research Centre, this is a core theme of our programme of work. Just as a reminder, intimal calcification sits and usually is within the lumen, and the medial sits around the it's circumferential, typically seen in kidney disease. Here's some histopathology slides that you can see, and this is medial calcification. You can see the von Cossa, the black staining in the middle. And interestingly, in patients with kidney disease, this is really severe. This isn't just a little bit of staining that you see. You start to see those smooth muscle cells start to differentiate towards proper bone cells. And in some, this is an autopsy study where you could start to see bone formation within the vasculature. So this is proper phenotypic change. During my PhD, we were starting to understand why these cells start to change towards osteoblasts, and it's not just calcium and phosphate being stuck and getting trapped in there. Actually, the cells start to change, and we know that phosphate can induce that differentiation of smooth muscle cells. So in my PhD, we were using phosphate to induce vascular smooth muscle cell differentiation, and we were measuring various osteoblast-like markers to see the extent of that phenotypic change and ability to calcify. So by the time I'd finished my PhD, and this wasn't just me, by the way, the global community had started to really understand the pathophysiology of vascular calcification, and that there was an active process rather than just physiochemical, and there were factors that were contributing towards development of calcification, but also reducing some of our naturally occurring inhibitors. And when you look at people with kidney disease, they had all the promoters of vascular calcification and lower levels of the inhibitors. And one of the lower levels, one of the markers that I found quite interesting during my PhD was this protein called matrix GLA protein. And it's a naturally occurring inhibitor of vascular calcification. We hope we all have lots of it. But if you knock it out in mice, you could see widespread arterial calcification. But it's a vitamin K dependent protein. And interestingly, vitamin K antagonists are used widely in medicine. And there was a calciphylaxis registry. If you recall, calciphylaxis is that rare, severe form of calcification. They found an awful lot of patients were on warfarin. They were on vitamin K antagonists. And so you could start to see how modification of these inhibitors of calcification could lead to disease and potentially provide also an opportunity for intervention. So we started to see growing interest in the area of vascular calcification because we now understand pathophysiology. So our basic scientists have provided us with the mechanisms to then target for treatments. So what we're hoping is that over the next 10 years, some of that will translate into effective strategies. And my research career, although it might have started in the basic science lab, that provided me with a really good foundation in understanding mechanisms and how we can then develop therapies. And calciphylaxis absolutely is a rare form of vascular calcification. And because it's rare, it provides an opportunity to study the disease in its severe form. And this is recommended, and lots of countries will designate diseases as orphan indication, and that encourages industry to develop products that gives them a more favourable environment. So when I became a consultant, we were seeing people with calciphylaxis in the department. So it seemed right that we would develop, that I would take that forward. It is rare, but the mortality, as you can see, is high, 45 to 80%. And hardly any of these patients have resolution of these wounds that happen because of calcification. And this is what happens. They get medial calcification, then the entire lumen gets blocked and they get tissue necrosis distal. So this is how it starts, fairly benign, but you're not getting oxygen to the skin. So it very rapidly breaks down to the point where you get necrosis. And this can be full thickness circumferential necrosis leading to amputation. So we collected data on people with calciphylaxis from around the UK. This was our calciphylaxis registry, which started in 2012 and has grown, and we now have sites across the country. We also joined forces with the Rare Disease Registry and developed a rare disease group there, which includes patients. And we published our data from, this is a few years ago now, Dr. Chinadura, who I hope will be the recipient of a MAHSC chair in the future. He's wonderful. But we found that absolutely the outcomes were terrible. Wound healing, again, very low, but bacteremia, hospitalization, and awful mortality with a median survival of only 4 months. So you'd think that something so devastating would have a raft of treatments. Well, I think the first thing to say is we know that they die. So we felt it was really important to provide guidance on how to manage these people, particularly around advanced care planning and pain control. So that was one of the first things Dr. Chinadora did with palliative care leads. But then we started to look at the management strategies in more detail. And there's loads of this stuff if you go on PubMed. But actually, it's all opinion, really low quality evidence. And we looked within the UK calciphylaxis study, and pretty much people were doing whatever they fancied. And you can understand why. They're desperate. They will give anything a go. So we then started to think about clinical trials, and at the same time, other people globally were also starting to do this. And industry had started to turn some of that mechanistic insight into potential investigational products. And here's an example of one. So this is the complex pathway. So many different factors associated with the development of calcification, but they developed a molecule, and they always come with these numbers and letters, SNF472, which looked at the final pathway and actually aimed to prevent hydroxyapatite crystals aggregating. So they developed their molecule and then wanted to test it. We did the phase 1 study, and then we went on to design the phase 2 study with them. And it was a small open label study, which gave all 14 patients the study drug. And when we measured their wounds, there was an improvement. When we measured their pain, there was an improvement, and their wound quality of life, there was improvement. So this was promising. We'd found an investigational product that could potentially support these patients using our knowledge from the mechanistic studies earlier. There's another slide which just says the same. And then recalling that calciphylaxis is an orphan designation that could potentially open the door to wider vascular calcification therapy, the same company undertook a larger randomized placebo-controlled trial in hemodialysis patients looking at vascular calcification as a whole. So much bigger numbers needed here, 2 doses of the drug and then obviously a placebo because we wanted to do a robust trial. And this was published in Circulation again a few years ago, which showed a reduction in coronary artery calcium. So if we're thinking about therapies that can help manage that increased cardiovascular risk, that increased calcification that we see through progression, here was a potential treatment that had shown some promise in phase 2 studies. And a phase 3 study hasn't happened yet, but hopefully will in the future. So the end conclusion of that was well tolerated, and the results look pretty good. So then coming back to calciphylaxis, we were keen to see if we could replicate the phase 2 open label study again in a robust placebo-controlled trial. So along came the Calcifix study. So I was the co-chair of the Global Steering Committee, and we designed this study, again, placebo-controlled, but then we wanted to make sure everybody had access to the drug. It's such a devastating disease that we wanted to look at the effects in an open label extension. We wanted all comers, so had to be on dialysis, apart from that, because it has to be given IV, and a diagnosis of calciphylaxis. We had a couple of surrogate endpoints, which was a wound score that, to be fair, hadn't been validated, and pain. So this is the poster. It was presented last November at the American Society of Nephrology. Don't worry, I won't go through it in detail. But the key take-home messages was that we designed a placebo-controlled trial. We did the first ever randomized controlled trial in calciphylaxis in the world. And yet the study was negative. So if you just look at the charts on the right-hand side, there was no difference between placebo and SNF472, which was disappointing, having spent 10 years of my life on this. But it did actually give us an important message that, one, we can do a clinical trial, and 2, we need to look at better tools. We can't just use surrogates. The other interesting thing, but important to say, this is post hoc, so it wasn't a primary, but it was an analysis that was mandated from a safety perspective, or rather the safety stuff was mandated. The analysis came post hoc. The safety signals were that it seemed to, in post hoc analysis, people on the drug seem to have less hospitalization, were less likely to die. I don't think we can really say any more than that, except that it's an interesting finding, and the drug itself was safe. So we certainly need to do more studies to look at that in a bit more detail. And the fact that we've done a phase 3 clinical trial globally hopefully means that we can do another more definitive hard endpoint clinical trial in the future. But there are other ways of doing trials. So we've also been working with colleagues in the University of Sydney. And so they have a clinical trial centre, which looks at slightly different ways of doing clinical trials, particularly in rare diseases. So we've got a trial called Beat Kelsey that we're hoping to bring to the UK in the next year. This is a platform design. If you don't know what that is, don't worry. But if you recall the recovery trial during COVID, where people were talking about dexamethasone, that was a platform trial. Worth having a look at, because I think we'll be doing more rare disease trials and more trials in general using platforms, because they're quite an efficient way of doing global trials. But you basically have a core protocol, and then you can add in different bits to it as you go along. So if there may be a new pharmacotherapy, you can add that in, or if there's a wound care piece or a dialysis piece, you can add different domains, and patients will have access to all of it. And we'll be leading the UK arm, and we've just applied for an EME grant, and hopefully we'll find out about that in July. But not forgetting our patients, we are also doing a qualitative study of what patient experience is like in this hideous disease, so we can at least try and raise awareness, but also provide support. So I guess this is my research career. It's been an absolute joy, and I've been very lucky, very fortunate, and I've had an opportunity to develop expertise in a niche area, working with basic scientists but trialists as well as industry leads. But I do think there is more opportunity to do with our MAHSC partners. So I'm keen to collaborate with any of you that are willing to do that. I've also realised that I'm looking at calcification in people who are already on dialysis, and that maybe there's an element of prevention that we can do. So I've started to develop a research portfolio outside calcification and looking at real world evidence and epidemiological studies. So I've got a few PhD students and mentoring a postdoc as well, and they're in a wide range of areas, looking at prevention, looking at multimorbidity, and hopefully trying to prevent people getting to the point where they get this awful vascular calcification and the terrible outcomes that I've just described. And this is very rewarding. But what I would say is, of all the things that I've described, probably the single most important research role was actually when I was appointed as a clinical director of renal services, which doesn't sound very researchy. But this happened in 2014, and it was the start of my sort of leadership development. And because my background was very much research, I couldn't not bring the two together. And there are huge advantages of combining research and clinical services. If you've got a research active department, you get really good appointments. You've got access to experts, you retain people, but your service improves because you're up to date. What I would say is, at that point, I was one of the only female clinical directors in the department, and that is reflected throughout the country. And I don't think this has changed very much, but this is medical directors, senior to me, but only just under a quarter of trust medical directors were women at the time. And I don't think this has changed. So we do need to work hard on medical leadership. But this is reflected in the research field as well. So this is my sister. So she's 22 years younger than me. And then whilst I was clinical director, she decided she wanted to be a scientist. So off she went to Nottingham to do her BSc in biochemistry. And so I started to take an interest in what her future would be. And it was a bit stark, really. And even though there has been some legislation, I think looking at equal opportunities and closing the gender pay gap, I was quoted 20 years. So she could expect that by the time she was in her 40s. She's progressing well, but I do worry about her long-term prospects, particularly when we continue to see these things like the leaky pipelines. So there's an opportunity to sort of combine the research and leadership as well as the workforce development bit. And this is my sort of leadership track. I went on from the clinical director to take on some regional roles, and I was appointed as the deputy director for R&I, but then took on a national role. And underpinning this was that research training that I got early doors, my patients, and of course my wonderful team at Salford Royal. More recently, I've taken on a deputy lead within the EDI, again, bringing that personal experience with my sister and her research, but also the health inequalities we saw with kidney disease. So I'm really looking forward to taking the EDI strategy forward for the BRC and CRF, and keen to hear from people who want to support that. And then as a national clinical director, I've got a real important role to sort of change policy or try and shape policy. It's an advisory role, so I'm not a decision maker, but we set up and this was before my time, NHS England had established a transformation programme, which really aligned with some of my values and what I wanted to do. And they had the three aims, which were around securing equity, ensuring quality of care, and improving value. And you can see how that really ties in with the aims of research as well. So ultimately, these are our goals. We want to absolutely see more people receiving transplants, getting their medicines optimization and early diagnosis, regardless of their protected characteristics. And as you've seen, some of the research and some of my PhD and MD students are really looking at what those barriers to research might be, how we can configure our outpatient services to provide really high quality care and prevention. That's really flipping things on the head for renal services. It might seem a bit obvious, but in renal services, we've largely focused on dialysis and transplantation. So bringing that research into policy and leadership within a clinical area is an opportunity that I've been trying to take forward. So what have I learnt to try and wrap up? Well, I mean, will be very grateful to Professor Kelra to have a mentor, and I think it is so important to have a mentor. I think I was lucky. He didn't seem to have any gender bias and had total disregard for any stereotypes. So perhaps I was lucky, but I think it's really important for me to pay that forward. Research absolutely enriches a career, and I'm not just talking about mine, but so many others. And it is one of the best parts of it is teaching and mentoring. So I'm grateful to have PhDs and postdocs. I work with almost anyone. The collaboration and the network side of it also makes it good fun. If there are any early researchers or any people thinking about doing research, then I would say it's almost always worth it. There are clinical benefits as well as research training benefits. And for me, patients are at the centre of everything I do. And that's not just me because I'm a clinician. Every researcher I've met, every industry partner who's trying to develop a therapy or trying to understand the mechanisms of a disease are always thinking about the end user, and that is the patients, our people. And teamwork is very much part of that. So what am I going to do? Well, the next steps are we are continuing to do some calciphylaxis global clinical trials. We're also working a little bit more in a more structured way with global partners around epidemiology and real world evidence generation in those long-term conditions and health inequalities. We have an NCA renal collection as well, which has tissue samples. So that will hopefully help our basic science and translational researchers try and make that leap into developing ideas and products. And then obviously, I'm biased. I want to continue developing translational research on vascular calcification. And from a leadership perspective, I want to see more of that coming into the policy side of things. I want renal to have a high profile. So we are working with the International Society of Nephrology to advocate for a greater profile for renal. If you didn't know it, renal disease is going to be the biggest non-communicable disease globally by 2040 and the second in Europe, second only to cancer. So we're all going to need to know about it. And again, supporting our local, the NCA, as well as the BRC CRF in addressing those health inequalities and delivering inclusive research. And absolutely will continue to do PhD and MD supervision and mentoring because that's just fun. So those are my acknowledgements. Obviously, my wonderful family, the husband, the team, my friends and Phil. Thank you. And I think I've just about finished on time.
Thanks very much, Smeeta. That was absolutely fantastic. Are there any questions from anybody? I think we've got a couple of minutes. Can I, whilst anybody's having a think, can I just kick off then? I have to say, Smeeta, that the referees that supported your chair application all commented on how generous you were as a collaborator, and I think that's really shone through your presentation today. One of the things that I was intrigued by, that you did a very hardcore basic science PhD, which I presume at times felt very far away from patients. So how do you think you benefited from doing that very fundamental type of PhD rather than a PhD in more clinical research?
I don't think I'd have been able to understand how to deliver a clinical trial if I hadn't done that. And the reason why I say that is a lot of the products that come through come from the lab. So in order to understand what we're trying to do to patients, it really helps to understand the pathophysiology and where the targets are. So for me, it does give me, it helps me speak a slightly different language. So I can speak to different people, and I'm able to translate. That can act as a bit of a translator between groups as well. So I think that's helped with the networking and the collaborative side of things. But I absolutely would not be doing what I'm doing now without that basic science bit. I do feel sad that I've lost a little bit of it. And so I'd be really keen to work with any researchers in the basic science field to try and pick up some of that, particularly because I've got those contacts now globally and can help pull that sort of knowledge and networking.
Brilliant. Yasmin, I think you've got a question.
Oh, thank you so much, Ali, and thank you so much, Smeeta. It was a brilliant talk, and I know we do have limited time, and yeah, I just wanted to ask about any key advice that you might have for our ECRs, and specifically when you mentioned your sister, but I know you briefly mentioned it by the end of your talk with few advice for our early career research. So I will jump to the second part of my question, which is about any, I would say, certain or major barriers that you might face during your professional journey and that you encountered, and how were they overcome by you think?
Yeah, I think this does come back to sort of what I said earlier about my mum. She just used to say yes to everything. She couldn't say no because she wanted to. She generally tends to try and help people, but she was quite a force of nature in that way. But the inability to say no is where I get it from. And some people would say that's a bad thing, but actually, by saying yes to opportunities means you get people coming to you with things. And at the beginning, it can seem quite stressful, and you don't want to pigeon yourself into one area. But actually, later on, you can say no, and people will only come to you with things that are interested. So I would say to early career researchers, say yes to everything, take those opportunities, and then talk to lots of people. But saying yes to opportunities, and sometimes luck just comes along. And if you find a career mentor, and also if you're thinking about if you're a more advanced researcher, finding someone to mentor is really good fun and really rewarding. So I think mentoring is really underplayed and of real value. Say yes and get a mentor. There you go.
Thank you so much, Smeeta.
Thanks, Smeeta, and many congratulations again on your appointment. And I'll hand back over to you, Yasmin.
Yeah, thank you so much, and congratulations again, Smeeta. And thank you so much, Ellie. So we will hand it over to Karen now for introducing Professor Nick Lees for the next talk.
Thanks, Yasmin. So I'm Professor Karen Piper-Hanley, and I'm the current head of division for diabetes, endocrinology and gastroenterology. And it's a real pleasure to introduce our new divisional MAHSC chair, Professor Nick Lees. So Nick is a Manchester boy. He grew up in Manchester and then impressively undertook medical training at Cambridge and Oxford universities, followed by junior surgical training. Once he'd passed the FRCS exam in 1996, he found himself back in the Northwest as a general surgical specialist registrar. In 2001, he was awarded a DM for his research into the molecular epidemiology of colorectal neoplasia, and he passed the Royal College of Surgeons of England Part 3 exit exam in 2002. So in 2004, he was appointed as a consultant general colorectal and intestinal failure surgeon at the Northern Care Alliance NHS Foundation Trust. Within a few years of becoming a consultant, Nick became concerned by the variation in processes and outcome for high-risk bowel surgery that led him to co-write the first Royal College of Surgeons of England Standards for High-Risk General Surgery in 2011. And he has been the Royal College representative on the National Emergency Laparotomy Audit since it started in 2013. In 2018, he led the Royal College Multidisciplinary Working Group that updated and expanded surgical standards, and all of this is being collectively recognised as greatly improving patient outcomes. Many of these processes identified have been taken up nationally, and Nick has been a major role in influencing this. Over the 20 years as a consultant, Nick has developed a basic clinical practice in high-risk bowel surgery for conditions including colorectal cancer and inflammatory bowel disease. He has grown a national practice in intestinal failure and managed patients referred from all around the UK with complications in need of complex multidisciplinary surgical care. In addition, he has been a busy trainer and educator and prepared over 1,000 senior surgical trainees for the FRCS Part 3 exam. In 2018, he was voted Public Servant of the Year by the City of Salford. Throughout his career, he's had the full support of his family, and I know that he enjoys walking in the Cumbrian Fells and skiing. And sadly, it's rumoured that he has been known to do panto, and if we were in a large room, you'd say, oh no, he hasn't. But oh yes, he has. So Professor Lees, it's with great pleasure to introduce your inaugural lecture, Surgery, It's a Risky Business.
Thank you very much, Professor Piper Hanley. It's a small world, so before we everybody else joined us on the line, Smeeta and I discovered we were on the same hill on Saturday, and I've just been exchanging chats with an old school friend I've not seen since I was 10. So it's a small world that we work in. Let me try and share my screen, and somebody will tell me if you can't see that. Let me try and work out how to get the show working. Can you see that at the moment?
Yes, that's totally fine.
Fine. Sorry, apologies for the slight delay. Thank you very much again for the warm introduction. It's very kind. And thank you very much to all those who contributed to my appointment as well. Again, extremely kind. Apologies for a second. I'm struggling to get the it's a forward. That's better. Hopefully you can still see. Apologies. So those are my declarations. I sit on a few committees. Nothing that I think will present as a problem today. As you've heard from that kind introduction, I grew up in Manchester. At an early age, somehow I seemed to be quite good at exams. I've got a few other things to boast about, but I was quite good at exams, and I got sent off to the grammar school. I enjoyed sport. I wasn't very good at sport. I couldn't make the school team. To be fair, everybody else in my class seemed to go on to play cricket for England, so I didn't have too much chance. I didn't do that. But I carried on being reasonably good at exams, and I guess that brought a certain sort of esteem of its own. So I went off to Cambridge for undergraduate medical school training, and then Oxford for graduate training. And in 1992, I found myself as what used to be called a house officer. I was a surgical house officer in Oxford. The cars there look slightly older than I remember them, but the point is that the John Radcliffe then looks similar to how it looks in that photograph top left before some of the later extensions. I worked hard. These are the old days. I don't know if they were good old days, but they're the old days of the 100-hour week. Over the Christmas in 1992, I seemed to be on virtually every shift. Patients in hospital over Christmas then tended to be there because they weren't very well. Quite a few died. A staff nurse kept calling me. The same staff nurse kept calling me, and I'd write the certificates, and she'd phone the relatives. And a couple of years later, we were married. It's not as sinister as that perhaps sounds. I then did medical house jobs in Northampton, and then it became time to choose what to do next. I decided I fancied being a surgeon, and I'd have a go at that. I was first generation doctor. Nobody had told me that if you wanted to be a surgeon, you're supposed to become an anatomy demonstrator first. By the time I'd realised that, all those jobs had gone. So I got the BMJ out and looked for surgical jobs. And the first one I saw advertised was in Salford in Shropshire for a surgical rotation. That's bottom left. And so I found myself in A&E in Shropshire in 1993. Again, very different than it is now. Doing the night shift in A&E in 1993, it was me as the SHO, one staff nurse, one enrolled nurse, and that was it. Compare and contrast with what an A&E department looks like now. I also realised I'd possibly backed myself into something of a professional cul-de-sac. The hospital had been open about 7 or 8 years, but nobody had ever passed a postgraduate surgical examination in that time. As I say, I was quite green and I was learning by my mistakes. But I knuckled down and I passed the primary FRCS. And I thought maybe I needed out of there. So I applied for some further surgical SHO rotation work in Cambridge and was fortunate to be appointed there. So I did orthopaedics in Addenbrooke's and then went to the old Papworth for cardiothoracics. On the first day, they gave me an on-call room key, and I thought that's very shiny. And I gave it back 6 months later, having not used it, understanding why it was so shiny. I quite fancied doing orthopaedics, and about a month into the cardiothoracic job, the head honcho of orthopaedics from Addenbrooke's came in to have his coronaries done at Papworth. Sure enough, on the third day post-op, he went into retention when I was on call. So we had a forthright chat about my chances of a registrar rotation whilst we sorted out his retention. And he said, fine, I'll sort you out, but you need to go and do some general surgery. So I went to do general surgery in Peterborough, not realising it was actually a 12-month post that would take me to Leicester. Again, I was still quite naive, but over the course of those 12 months, realised I quite enjoyed general surgery and colorectal surgery in particular. So by now we're in 1996 and I was in need of a registrar rotation. There were jobs coming up in Cambridge, but the first to advertise were up in Greater Manchester in the northwest. So I told my wife I'd go up for the interview practice. It was midweek. I came up and was interviewed and sure enough was appointed to the job. It was the Euro 96 was on. England were playing Holland. For those old enough or interested enough to remember, England won 4-1. My wife and I were the only ones out having dinner that night in Cambridge whilst we discussed whether or not we're going to move to Manchester. There's Gascoigne holding his fingers up saying, that's 4 years of a junior doctor and you've now got a registrar job, Nick. So I found myself back in Greater Manchester. I knuckled down as a surgical registrar, but a couple of years in, realised that really I wanted to do some research and I started doing a doctorate at Wythenshawe and Christie's. That involved an awful lot of endoscopic work at Wythenshawe. John McLaughlin was doing his PhD at the same time, and I think between us, John and I scoped pretty much every inhabitant of South Manchester over the course of 2 or 3 years in search of samples and data. And a few papers were generated, and truth be told, I quite enjoyed seeing my name in print. I tried writing some things as an SHO, but they were pretty amateurish, and I learned quite quickly, if you're going to do research, surround yourself by people that know what they're doing and listen to them. And I learned a lot quite quickly. Surgical registrar years completed. By 2002, I was a senior specialist registrar and I found myself at Hope Hospital doing colorectal on a well-regarded unit, and in particular a unit that was specialising in something called intestinal failure, something I'd not really come across before then. This is a condition in which we take patients who've suffered complications of previous surgery. We take referrals from up and down the country and working in a multidisciplinary fashion, slowly but steadily, hopefully turn things around and I hope to get their lives back on track. So I stayed here as a senior reg for 18 months and then was appointed as a consultant, and I've been here ever since. So in 2004, I was appointed a consultant and set about my clinical practice, mainly in colorectal cancer, inflammatory bowel disease, and as I say, intestinal failure. Quite quickly, it became apparent to me that it was quite hard work. A colleague said, don't worry, it gets easier after 20 years, just knuckle down. I found myself in here more weekends than I should, and I started to notice that there's quite a lot of variation in care. I started to get slightly frustrated that patients who were clearly ill, having come in with a perforation or peritonitis, I'd have to negotiate hard to get them to theatre, often competing with other specialties, conditions or pathologies that didn't seem to be quite so serious, but people perhaps failing to grasp the seriousness of the situation. I also found myself in, as I say, most weekends if I didn't like the look of one of my own patients, and it all became, it felt quite personal, the battle to look after your own patients. And I thought, surely there should be a way we can do this in a slightly more systematic fashion. We enjoyed some successes. A colleague moved on and I took over leading the colorectal cancer team. I threw myself into that with a fair degree of gusto, and we were voted Trust Team of the Year in 2008 on the back of an external peer review. And I started taking on some roles outside of the Trust. I also had an interest in audit and saw a value in big data and took on, amongst other things, this audit of stoma complications with one of our juniors at the time, Kat Palmer, whose name will come back in a second. But as I say, a few years into the consultant job, I thought, really, we ought to be able to do something further about this unwarranted variation. Why does it depend on what day of the week it is or what time of day it is before it's determined how quickly your patient goes to theatre if they're ill with sepsis? Why does it depend on individuals coming in at the weekend when they're not on call to spot that their patient's not well? Why don't we have a system that's more routinely safe than that? And what can we do about it? It's not like we were short of data to point to a problem. This is national data from the Crit Care Society by the mid-noughties, showing that patients who are septic got sicker the longer they waited for antibiotics or the longer they waited for surgical source control. So we knew that. And what's more, it was demonstrated by Rupert Pearce, an intensivist down in London, that you could identify which patients were going to be high risk. These are readily identifiable just using data that we use to plug patients into the NHS database. We know who are the high risk group. They contribute the large majority of the deaths after surgery, but very few of them were actually routinely admitted to critical care. Why is that? Also in the noughties, this concept of failure to rescue was coming to the fore. That's to say that it was recognised that all hospitals, those with good outcomes and those with poorer outcomes, they all have patients who suffer complications after surgery. But what differentiates those hospitals with the better outcomes from the rest are those who are able to spot and rescue patients from their complications. So these concepts were mulling around. We had evidence from the UK from the first limited emergency laparotomy audit. This was a relatively small audit, a little over 1,000 patients from 30 units, but it demonstrated massive variation in outcome. Some units were returning mortality rates of 3% and others returning mortality rates of 40% after, on the face of it, broadly the same operations. You'll spot some names there: David Saunders, Dave Murray, Carol Peden. I'll come back to some of those in a minute as well. So it was against that backdrop that some of us came together in 2011 under the auspices of the Royal College of Surgeons and said, what can we do to start to standardise some of the chaos? And we wrote the first Royal College of Surgeons standards that started to describe, for example, which surgical patient should have a consultant surgeon based on their degree of risk, a consultant anaesthetist, who ought to go to intensive care, etc. And one of the recommendations was that we should set up a national audit to study this area more closely. And I was appointed as the first Royal College of Surgeons of England representative on the clinical reference group for that audit in 2013, and that's a role I've stayed in ever since. All trusts put in their data. Initially, a little over 20,000 patients a year were going in. It's more per year now. And sure enough, this was high-risk surgery with 30-day mortalities of nearly 12%. Half of these patients are elderly, but very few were seen by geriatricians, surprisingly. As with the small audits that came earlier, we demonstrated that there was wide variation in time before patients were reviewed by consultants, variations between hospitals and variations depending on the time of day. you're more likely to be seen by a consultant during the day than overnight or at weekends. And patients with peritonitis or sepsis were waiting an unreasonable length of time for treatment, including antibiotics. Most patients were getting their operations done by consultants, but a significant minority were not. And those patients who were operated on overnight or at weekends, inevitably when surgery is likely to be higher risk, otherwise you wouldn't be operating overnight or at weekends, they were less likely to get senior involvement in their care. And in particular, we noted it was important to assess the risk, and it became clear that a significant proportion of our colleagues perhaps hadn't recognised just how risky this surgery is. What's more, if you fail to assess risk, it became clear that that failure itself was associated with patients being less likely to receive these protective standards like consultant-delivered care, and it was associated with excess mortality. So we spent the next few years trying to educate our colleagues, going to every national meeting, going to academic health congresses and the like, spreading the word. And we started to see some improvements in process and improvements in outcome. So assessment of risk improved, consultant attendance for high-risk cases improved, geriatrician involvement improved, but still from a low base, and mortality started to improve. And if you knock 2% off mortality for an operation where we do 30,000 of them a year, you start saving a few hundred lives a year, year on year, year in, year out. And we also started saving money because length of stay came down as patients experienced fewer complications. But it wasn't all perfect. Still, patients with sepsis were receiving their antibiotics late. Those patients that needed surgery particularly promptly seemed to have most difficulty getting to surgery in a quick fashion. So we started looking around at other areas where we needed to make progress. Nick Simmons in London, again, identified the high-risk groups, not just of patients having surgery, but those managed non-operatively, and demonstrated that if you compare those patients, those hospitals who are, as it were, the good outliers from those hospitals who are the worst outliers, there's variation in use in critical care and variation in access to radiology. So the mantra seems to be scan early, scan often, and send to critical care for the high-risk patients. So it became clear to me that we'd achieved a certain amount, but we needed to go further. We needed to raise the bar, and perhaps we needed to incentivise those achievements. So in 2018, I led this work, and I guess this is my magnum opus, as it were. I led the Royal College of Surgeons working group that went further than we did in 2011. Something I'd learned over the years is if you're trying to get something done, work with good people. And so some of that'll be too small to read, but some of the names in there, Carol Peden, Nick Simmons, Rupert Pearce, and others. They're people who had been involved in this area previously, and people I'd worked with previously in the 2011 iteration of this work, which made it all, I think, easier by working with good people. So what was new? Well, the first thing we did is we clarified the message. We'd gone a certain amount in 2011, but we cleared it up. We clarified the mantra and said for high-risk patients with a predicted mortality of 5% or above, you will always get a consultant surgeon, a consultant anaesthetist, and a critical care bed. No ifs, no buts. We also took an interest in frailty, which was relatively novel at this time for surgical conditions, but we recognised that work was being done around frailty, and we sensed that frailty could be measured, and if you did measure it, it would predict poor outcomes, and you could put in protective systems for these group of patients if you recognised it. So we put standards in around frailty. And fortunately, we were proved right. A couple of years later, this was published by Kat Palmer, who had been my junior doctor way back when I was a young consultant. She led a group that demonstrated that indeed you can measure frailty in patients undergoing laparotomy, and you see a dose response curve. It predicts mortality. As a spin-off, because of our work in this area, I then got involved in writing guidelines for patients living with frailty undergoing not just emergency, but also elective surgery. One thing I discovered is if you start writing things, you get invited to write more. These things tend to mushroom. What did Nella tell us about frailty? Well, our suspicions were proved right. We lowered the age in which frailty should be measured from 70 to 65. And we demonstrated using the Nella database that those patients undergoing emergency laparotomy where geriatricians were involved saw a 40% lower mortality than where they weren't, which is fairly, well, more than slightly impressive. Clearly, this is observational data. It's not randomized control data. But if it's not real, then it's a heck of a coincidence. Sepsis. Means of identifying sepsis had been around for several years. We'd been looking at SIRS, we've been looking at QSOFA, but work was starting to come out to say that the National Early Warning Score was a more sensitive predictor of patients' outcome when they were admitted with sepsis than other measures. It predicted admission to critical care, it predicted death. And so we recommended that the new score was used to identify surgical patients with sepsis, and that's become embedded in national practice since. We also recognised that time to source control, i.e. time to surgery for patients with abdominal sepsis, was likely to be an important predictor of outcome, and data from the National Emergency Laparotomy Audit bore that out. For every hour that passed after patients were admitted with a perforated peptic ulcer, the risk of mortality grew by 4%, or if they were shocked, by 6%. So we built in rules into our standards that dictated, and dictated probably is the right word, how quickly patients should get to theatre if they're septic and they're admitted under a general surgeon. And we built all that into a best practice tariff, which then meant that trusts were now rewarded financially if they abided by our standards. And to put that the other way around, they were paid less if they didn't. And money talks. And over the course of just 1 year, trusts abided by those standards considerably more than the year before. And so we saw some further progress and some further reductions in mortality. But then, of course, the pandemic kicked in and things ground to a little bit of a halt in terms of our ability to teach the NELA standards. I became involved in writing standards for care outside of critical care units. Critical care units were, of course, in massive demand during the pandemic. So we needed care on the wards, and I was involved in writing standards to maintain care outside of critical care. And we started to spread the word internationally. So the same standards and the same results we're seeing nationwide, we started to see internationally. And the same standards we'd written UK-wide, we started to write internationally for patients undergoing laparotomies. In 2022, I got involved in writing the antimicrobial treatment standards for the UK. These impact on 1 million people a year treated in the UK for infection, and they're now becoming embedded, hopefully, in all trusts UK-wide. Throughout all of that, I carried on with the day job, continued to look after my patients as best I could, receiving referrals from up and down the UK, and enjoyed, I hope, respectable outcomes with no deaths over a 5-year period. I was honoured and humbled and slightly embarrassed to be rewarded publicly. For those of you who are old rockers, that's Peter Hook from Joy Division presenting me with an award a few years ago. We've embarked on quite a lot of teaching. As you heard in the very kind introduction, I've helped train 1,000 senior trainees and prepare them for their exit exam to allow them to become consultants. I'm incredibly grateful to so many colleagues, too numerous to name all of them. My secretary is probably the most long-suffering, and the group down the right-hand side are all those who very kindly supported me in my MAHSC application. It's important not to take yourself too seriously, and you can't in the outpatient clinic in Salford Royal, so that keep your feet on the ground. And throughout it all, I've been extremely fortunate to have the love and support of my family, without which I guess I wouldn't have done anything like as much. Thank you very much for listening.
That's absolutely fantastic. It's amazing to see the work that you've done, both locally, nationally, and internationally. And what an absolute honour to be presented with an award from Hookie, which is fantastic.
Yeah, it was taken somewhat by surprise. I was just in my office doing admin one day, and the phone rang. It was a typical day with all the usual chores. I answered the phone. I'm not sure. I suspect I was slightly grumpy. I didn't say anything adverse, but it would have been the usual yes, what kind of tone of voice, I suspect. And it was the mayor's office. So the moral of the story is be careful how you answer the phone. You never quite know who's on the other end.
That's amazing. We'll have to catch up on that one. Does anybody have any questions that I can field? Just a very quick one from me. I just wondered, given that we've had the COVID pandemic, I just wondered whether you felt that, the negative impact that that's had on everything that you've implemented so far, or whether it's not really impacted it at all.
I mean, it definitely has impacted. I mean, the pandemic's impacted, but the financial impact on the NHS has probably impacted at least as much. So the NHS was, as we're all aware, starting to struggle before the pandemic. The pandemic just doubled down, really. In fact, mortality after emergency laparotomies, would you believe, fell during the pandemic. But it fell, I think, for combinations of reasons. We were slightly more selective who we operated on. So where the balance of risks and benefits was borderline or marginal, there's a greater tendency to treat patients non-operatively. What's more, those patients who did receive emergency laparotomy care absolutely got consultant-delivered care, both in theatre and out of theatre. And as I say, slightly counterintuitively did better than in previous years. The pleasing thing to me was just how many patients, both elective and emergency, still received major surgery throughout that time, be that through critical care or on pop-up enhanced care units outside of critical care, units that actually continue to this day as hospitals try to recover from the pandemic. But yeah, I think the biggest challenge to high-risk surgical care going forward are resources, and straightened times and tightened resources are our biggest challenge, I think.
Great. Does anybody? Oh, we have got one question.
Hi, Karen. It's Dave Shapley.
Hi.
Yeah, Nick, it's a great story you tell there about all this incremental progress. Great to see so many Manchester names there alongside your own as well. I saw Ian's and Gordon Cowson's name quite a bit in some of that. I just wanted to ask, because there's been a bit of controversy in Manchester about Healthy Together. So both your view and what does the data tell us on the current understanding about high volume centres with outcomes from laparotomy? Because I can see on the one hand, there's experience, more consultants around, more numbers, higher levels of care in a centre of excellence versus the delay to intervention. So at the end there, you pointed to speed's important in getting patients to theatre. I always thought the high volume argument was more powerful. I just wondered what the latest.
Oh no.
I lost the very last end of David's sentence, but I got the message. Can people still hear me? Somebody nod.
Yes.
Yeah, sorry.
So yeah, I mean, I think in terms of the evidence, it's difficult, David, as you'll appreciate. There's no randomized data on this kind of stuff. There never will be. The vast majority of stuff we wrote standards on, there's no randomized data, of course. There's a lot of extrapolation by experts from the data that is available. Though you'll be familiar with it, others perhaps less so, that Healthy Together envisaged an environment in which patients might be directed to a smaller number of centres majoring in this work, even if that meant that the ambulance would spend an extra 15 minutes on the road to be met by consultants at the other end who specialised in this area. The NHS has thrown quite a lot of money at it on the back of a public consultation and a lot of political work that several of us, myself included, were involved in. The trusts have taken the money and the buildings have gone up, but the transformation work has stalled. The story behind that is for another day and would require an awful lot of time. I think the principles are being operated by people who specialise in a condition still abide, as long as you can avoid unacceptable delay in getting the patient to the people that can treat them. There's an awful lot of extremely avoidable delay in the system. Most patients having an emergency laparotomy have it after 12, 18, 24 hours from admission to hospital. An extra 20 or 30 minutes in the back of an ambulance is kind of small potatoes against that backdrop. But can I show you randomized control data? Absolutely not, no.
Great. Well, I think we better stop there, but I would just want to say congratulations to both Nick and Smeeta. It's been absolutely fantastic. And I'll hand back to Yasmin.
Thank you so much, Karen, and thank you so much again, Professor Lees, for the brilliant talk. So I think this is the end of our event here, and I would like to thank everyone for joining us. And once more, congratulations again to Professor Sinha and Professor Lees. And we wish you all the best for your future plans. Thanks, everyone.
Thanks very much.
Thank you.
Cheers. Bye.
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 Bye.